All right, friends, welcome back to Discussions with Dr. G. I'm Dr. G, your cat-loving acrylic painting enthusiast and pharmacology professor. So let's jump in with that glamorous topic everyone loves, fluid overload. Yeah, I know nobody wakes up thinking, let's talk about third spacing today. But in clinical practice, this stuff is everywhere. So when we say fluid overload, what we're actually talking about is too much extracellular fluid, sometimes in the blood vessels, sometimes leaking into the tissues, or if your patient's having a real party, in both. And honestly, I've seen it all from heart to kidney failure and those overzealous IV infusions when someone decided saline was basically free. So what actually causes fluid overload? Heart failure is probably the most famous culprit. The heart can't pump, so the kidneys freak out, squeeze out the RAS hormones, and the next thing you know, your patient's holding on to sodium and water like it's Black Friday at the mall. Then you've got renal failure. If your kidneys go on strike, nothing's getting filtered. Liver failure is another lose your albumin and your fluids. Well, they're just kind of oozing out of the wrong places. And then we have good old iatrogenic causes. You know, when we in healthcare accidentally give folks a wee bit too much IV fluids or blood products. Whoops. You'll see the signs. Patient short of breath when lying flat, so they're propped up on 6 pillows. Crackles in the lungs. Nocturnal dyspnea, so they're calling their nurse every hour at night. Cardiac-wise, maybe they have hypertension, jugular veins that pop out like little blue straws, classic swelling around the ankles, and my favorite, why do I weigh 7 pounds more than I did yesterday? If fluid makes it up to the brain, we're talking confusion. Down to the belly, ascites, and malabsorption. It's one big watery mess. And this is exactly why we bust out the diuretics for management. These drugs basically tell the body, hey, it's time to evict some water and sodium. Gotta improve gas exchange and perfusion and get those shoes back on our patients' feet. So probably my funniest moment is one of my first nights as a new grad. I had a patient who got marathon fluids, and by morning, neither of us could get their shoes on anywhere near their feet. I felt so bad, and I thought, gosh, I hope nobody calls a code. Missing footwear. Anyway, lesson learned. Always check those I's and O's. Now let's get nerdy for a second and break down why that fluid actually ends up where it shouldn't. You got to think in terms of fluid movement. The basics, hydrostatic pressure, and that's the push of fluid out of the vessels like a garden hose that won't quit. Then there's osmotic pressure, which is the pull of water back in, mainly from dissolved stuff like sodium. Colloid oncotic pressure? That's the special pull power of albumin, keeping fluid in the vessels, sort of like a bouncer at the club door. Sorry, interstitial space, you're not on the list. So edema. That's the visible swelling. Happens for a few basic reasons. Too much push, high hydrostatic pressure from the heart failure. Not enough pull, low oncotic pressure from liver disease. See ascites, anyone? Holes in the walls, increased capillary permeability. You'll see this in sepsis or injury. Or a roadblock in the exit lane. Lymphatic obstruction, classic post-mastectomy, or with lymphedema. And when all that fluid is misplaced, gas exchange goes out the window. The heart is working like it's running a marathon, and the kidneys just throw their hands up. That's why nurses are always hawk-eyed over these patients. You got to watch for subtle changes. A little weight gain here, new crackles there. These are actually really big deals. I once had a patient gain 3 kilos overnight, and if you ever want your heart to skip a beat, just try explaining to a cardiologist why you missed that. So always assess, reassess, and trust those daily weights and lung sounds. If something feels off, it probably is. All right, let's talk about the celebrity cast of diuretics. We've got your thiazides, loops, potassium sparing, and the wild child, osmotic diuretics like mannitol. If you're picturing them in reality shows, I don't blame you. Each has their own drama and dirty little secrets. Start with thiazides. Hydrochlorothiazide, or HCTZ. This is your old standby. This crew works at the distal convoluted tubule, blocking sodium and chloride, so out goes water. Good for hypertension, mild heart failure, and sometimes weird things like preventing kidney stones. Watch out if your patient's got sulfa allergies, is pregnant, or has no pee output. Major side effect? Orthostatic hypotension, constipation, photosensitivity. But the showstoppers are those lab changes. Hyponatremia, hypokalemia, lithium, and digoxin toxicity. Always remind folks to take it in the morning, eat potassium-rich foods, and if you see muscle cramping or weakness, say something. Next up, loop diuretics, furosemide. That's Lasix for old schoolers. Absolute powerhouse, but with great power comes great responsibility, right? Acts at the loop of Henle and can drop fluid and pressure like nobody's business. Indications? Heart failure, pulmonary edema, cirrhosis, you name it. But they can dry people out dangerously and tank potassium even worse than thiazides, so mind those potassium labs. GI upset, constipation, and the infamous ototoxicity if you push it IV too fast. Trust me, you only have to see one patient turn hard of hearing post-Lasix before you never forget that lesson. Daily weights, blood pressure, and very close potassium monitoring, or the cardiology folks are going to chase you down the hall. Potassium-sparing diuretics like spironolactone. They're a bit more chill, mainly used for mild cases or to keep potassium up. They go after aldosterone in the distal nephron, which means you keep potassium, lose water and sodium. But, big but, these are contraindicated in pregnancy, renal failure, or if you're already running high in potassium. Fun side effects. Weird hormonal stuff like gynecomastia, menstrual changes, you name it. But here's the kicker. Severe hyperkalemia. You don't mess around with arrhythmias. One patient having syncope taught me never to ignore a potassium level. Absolutely no potassium-rich foods, please. And remind your students, because I once had a newbie buy those electrolyte drinks thinking more potassium was good no matter what. Yeah, not so much if you're on spironolactone. Last but not least, osmotic diuretics like mannitol, the ones you see in the neuro units. These pull fluids into the renal tubules by amping up plasma osmolality, so it's rapid acting for things like increased intracranial or intraocular pressure. But, and this is very important, never use with renal failure, active brain bleeds, or pulmonary edema. Side effects: headaches, nausea, plus a whole kettle of electrolyte fish. Initial hyponatremia and then hypernatremia, and if you're not careful, you get rebound high intracranial pressure or pulmonary edema. Always run mannitol with a filter, monitor everything from neurostatus to urine output, and if no pee shows up, stop it immediately. No exceptions. Please trust me. So across all the classes, you got to be a hawk with electrolytes, monitoring ins and outs, getting your daily weights. Seriously, it's not just busy work. Always dose diuretics in the morning. Nobody likes midnight bathroom marathon runs. Teach your patients to rise slowly, eat the right amount of potassium for their drug, and recognize the weird stuff early, like cramping, palpitations, tingling, all that. And never forget those nasty safety alerts. Digoxin and lithium risks with thiazides, severe hypokalemia with loops, arrhythmias with potassium sparings, and rebound intracranial pressure with osmotics. Honestly, I know it's a lot, but you can always break it down. Recognize the cues, analyze and prioritize your risks, act quickly, and evaluate. That's the essence of good diuretic management. All right, that'll do it for today. A real whirlwind tour through the fluid jungle. Next time, we'll keep decoding more myocardial and renal adventures. So stay curious, stay caffeinated, and stay safe.